Hi everyone. If you're a NEETPG aspirant or FMG or INICT aspirant, this video is for you, right? So let me tell you how this video is going to help you. So in the first place, I know all of you are putting your heart and soul in your NEET-PG preparation or the PG entrance preparation, right? So in between, I want you to focus on this video because I'm going to post videos on tests and discussion in the form of tests and discussions, right? So let me tell you how. So a test link will be given in the description box below. So I want all of you to go attempt the test. It'll not take more than 10 minutes, right? So attempt the test and the discussion part of those MCQs will be this video. All right. So I'll be posting a series of videos which is going to help you in your preparation because tests and discussions will do wonders in your exams. All right. So let's start off with the discussion. But before that, I want you to know how you're going to prepare for your entrance examination. So I know all of you will have, your own individual strategies which you will be following. So I'll just give you a few tips on it. So first of all, look into pick any course. Yes, pick any one course and do some revision videos, right? So do revision videos in such a way that you cover all the 19 subjects. Yes, do revision videos such a way that you cover all 19 subjects. This is the first thing that you will do in your preparation. After that, attempt test and discussions. So there are tests and discussions available in various platforms. And in this, series of YouTube videos that I'm going to post, I'll be focusing more on this part. So I'll be providing you a test link, which is in the description box below. And you just attempt the quiz and find out the answers, identify where you're lagging behind, and then come back to the video and watch the discussion part. Right. So this test and discussion is what is I'm going to follow. I'm going to focus on through these videos. Next is you can give grand tests. And what my personal advice is that you can avoid giving grand tests at 1 month before your exams. So before that, you can give your grand test, analyze. It is mainly for time management. And next things, the last thing that you can do is revise your notes. So while watching the revision videos itself, just have your own notes, right? Just revise your notes. Notes will not be like you shouldn't have books of notes, right? But you just have to have just points on your notes. Yes, so revise those notes as many times as possible, right? So these are the 4 tips that I can give you for preparation of any PG entrance examinations. All right. So yes, so we'll move on to our discussion part. So before watching the discussion part, attempt the test, right? So the first question says, glucagon activates all except. So what is this glucagon? Activates all except lipolysis or ketogenesis or gluconeogenesis or glycolysis. So what is the answer? The answer is going to be glycolysis, right? The answer is going to be glycolysis. So why is it glycolysis? For which let's just have a few concepts and facts. We will learn it. So glucagon, what is glucagon? Glucagon is a hyperglycemic hormone, is it? So glucagon is a hyperglycemic hormone. So it basically increases the blood glucose levels. How does it act? It acts by GPCR pathway. So the first thing is the glucagon will bind to the GPCR receptor, that is G protein coupled receptor. Then it activates, you have alpha, beta, and gamma, 3 subunits which are attached to this GPCR receptor. Now this alpha subunit will bind to GTP and gets dissociated from the beta gamma. It will activate the enzyme called as adenylate cyclase. Now this adenylyl cyclase in turn will convert ATP to cyclic AMP. So the glucagon acts by increasing the levels of cyclic AMP. Now this cyclic AMP will activate protein kinase A and phosphorylates various enzymes and activates the enzymes by phosphorylating them. So as you know, it's a hyperglycemic hormone. What are the different carbohydrate pathways that it can activate? Yes, so glucagon can activate gluconeogenesis. Is it? Glucagon can activate gluconeogenesis. Glucagon can activate glycogen breakdown. So glycogenolysis. So these two are the pathways that glucagon can activate. Whereas what is insulin? What's the function of insulin? insulin is a hypoglycemic hormone. Yes, insulin is a hypoglycemic hormone. So basically, it is required to decrease the levels of blood glucose levels. Or in other words, what you can say, it is helping in utilizing the glucose by the cells. So how does it act? It acts by tyrosine kinase pathway. Yes, it activates by, it gets activated, it acts by tyrosine kinase pathway. My spelling is wrong. Anyways, so tyrosine kinase pathway. So it has alpha group and beta. So when insulin binds to the receptors here, what happens is the tyrosine residues are phosphorylated by tyrosine kinase enzyme. After that gets phosphorylated, it phosphorylates something called as IRS. So insulin response substrates. So when they get phosphorylated, they activate various other pathways, right? By activating second messengers or by activating MAP kinase pathway, right? So this is how insulin acts. So how does insulin act? So what does insulin do? It's a hypoglycemic hormone. So what are the carbohydrate pathways that it can activate? It can activate glycolysis. Yes, it can activate glycolysis. Also, it can activate glycogen synthesis. Is it? And basically, insulin is an anabolic hormone. Yes, insulin is an anabolic hormone. So it will activate lipogenesis. Yes, it will activate lipogenesis and also protein synthesis. All right. So now that you can find out the answer for this. Yes, so glycolysis. What activates glycolysis? Insulin activates glycolysis, is it not? So glucagon activates all except the answer is going to be glycolysis. So whereas all the other pathways are activated by glucagon. So this is what is about. This question is about. Next. A 4-year-old child presents with easy fatigability, increased hunger between meals, which is relieved after food. Liver biopsy reveals no glycogen. Yes, liver biopsy reveals no glycogen. So there is no glycogen in the liver. So what does it mean? What is a likely deficiency? So when there is no glycogen, there is no glycogen synthesis. So what logically the enzyme can be? The enzyme that is deficient can be the glycogen synthase enzyme. So when the glycogen synthase enzyme is deficient, the glycogen synthesis itself will not happen. So glycogen is not available in the liver, because liver stores glycogen, is it? Also muscle. So this is what is about the glycogen synthase deficiency. So what is this glycogen synthase deficiency? How do you classify it under? So you classify it under glycogen storage disorders, in which the type 0 is what is the glycogen synthase deficiency. So this will present with hypoglycemia, of course. When your liver glycogen is absent, your liver glycogen is absent whenever you need glycogenolysis can't happen. Yes, so that's why it leads to hypoglycemia and also hyperketonemia. So other pathways get activated, so ketone body synthesis will happen. Then early death, right? Because there is no glycogen, so glucose is not able to be formed in the form of glycogen. So usually glucose is stored in the form of a polymer, which is the glycogen, because you want to make it a compact structure. So much of glucose moieties are just made into a compact structure, which is glycogen. So when this is not available, of course there is early death, and also because of this hypoglycemia. Next is type 2A. Type 1A. Type 1 is very important type, which is the von Gierke's disease. So what is it due to? It's due to deficiency of glucose 6 phosphatase. So this is very, very important. So when glucose 6 phosphatase enzyme is deficient, what happens? It leads to hepatomegaly. Yes, it leads to hepatomegaly. There is fasting hypoglycemia, hyperuricemia, hypertriglyceridemia, and lactic acidosis. All right. So glucose 6 phosphatase enzyme, when it is deficient, then this enzyme is what will give us the glucose in the last step. So when this enzyme is deficient, there is the glucose, blood glucose levels can't be increased. No. So that will lead to hypoglycemia, and also all of which will get accumulated in the liver, so it leads to hepatomegaly, right? So all the glucose 6, why is there hyperuricemia? All of the glucose 6 phosphate will be channeled to the pentose phosphate pathway or the hexose monophosphate shunt pathway. Mainly what happens there, ribose 5 phosphate gets activated, so more of which will be produced, so more purine synthesis, so more purine breakdown, which is what will lead to hyperuricemia, right? So likewise, then hypertriglyceridemia and lactic acidosis, because the other pathways are getting activated, that leads to more pyruvate, more lactic acidosis. All right. So this is how you learn von Guericke's disease. Type 2 is what is Pompey's disease. Pompey's disease, there is pump failure. Which organ pumps? Heart pumps. So there is cardiomyopathy, which is a distinguishing feature in the Pompey's disease. It is due to acid maltase. Next, type 3. What is the third alphabet? It is C. So there is Cory's disease. Now C, what is the next alphabet of C, which is D, which is the deficiency of D branching enzyme, right? Next is debranching enzyme again. What is the how do you differentiate it from von Guericke's disease? Debranching enzyme deficiency. In addition to hepatomegaly and hypoglycemia, there is exercise intolerance because this enzyme is present both in the liver as well as in the muscle. Whereas in von Guericke's disease, this enzyme is present only in the liver. It is not present in the muscle, right? Next is type 4. Type 4 is Anderson. What is the next alphabet of A, which is B? So Anderson enzyme deficiency is branching enzyme. So branching enzyme is an enzyme of glycogen synthesis. So synthesis part is affected. So there is limit dextrinosis, which is happening. I mean, limit dextrins are getting accumulated in the liver. So there is hepatosplenomegaly, cirrhosis, and also skeletal muscle defects. Type 5 is McArdle's disease, which is M4M, muscle phosphorylase. So muscle exercise intolerance is there. Type 6 is Hirsch's disease, liver phosphorylase. So there is again liver hepatomegaly, hypoglycemia is there. Type 7 is what is Tarow's disease, which is due to phosphofructokinase 1 enzyme deficiency, which is an enzyme of glycolysis. So here, what is the distinguishing feature? You have exercise intolerance in addition to hemolytic anemia because it's an enzyme of glycolysis. Glycolysis is the only pathway that can give ATP in an RBC. So when this pathway gets defective, then there is hemolytic anemia. So these are the various glycogen storage disorders. So we've just seen it in a glance. Moving on to the next question. So a 2-month-old infant is brought to the pediatrician with a history of feeding difficulties, vomiting, poor weight gain. On examination, the infant has jaundice, hepatomegaly, and cataract. So it's a 2-month-old infant. We're breastfeeding, right? So there is jaundice, hepatomegaly, and cataract. Lab investigations show us hypoglycemia, hyperbilirubinemia. So what's the possible deficiency? So there is something, cataract in a newborn is going to be because of galactose metabolism defect. Okay, so there is the only possibility. Cataract in a newborn is going to be galactosemia. But as you can see, so you can just rule out lactase deficiency, right? So you can rule out lactase deficiency. Lactase deficiency leads to lactose intolerance. So this is not it is. Next is galactokinase. You have the enzyme galactokinase, galactose 1-phosphate uridyl transferase. So what do you think the enzyme deficiency would be? Galactokinase is nothing but it's deficiency will lead to galactosemia. But galactose 1-phosphate uridyl transferase, the deficiency of which will lead to classical galactosemia. Right. So what's the difference between just galactosemia and classical galactosemia? In galactosemia, there is just the presence of cataract. But classical galactosemia, you have severe symptoms like jaundice, hepatomegaly, so everything together. So that's more severe. So classical galactosemia, since you have hepatomegaly, jaundice in this patient, so you're going to choose galactose 1-phosphate uridyl transferase as the answer, right? So a few points on the galactose metabolism. galactose gets converted to galactose 1-phosphate. So any sugar is going to be trapped inside a cell by addition of a phosphate. So if it's glucose, you form glucose 1-phosphate. If it's a fructose, you form fructose 1-phosphate. If it's a galactose, you form galactose 1-phosphate. So this is a mechanism by which you can trap the sugar inside the cell, right? So with the help of ATP, now I have used the phosphate and I have made it to be galactose 1-phosphate. Then that gets converted to glucose 1-phosphate with the help of UDP glucose, with the help of the enzyme galactose 1-phosphate uridyl transferase. So if this enzyme is deficient, that's what will lead to classical galactosemia. So now what happens here? In classical galactosemia, my galactose 1-phosphate levels also will be high. Galactose levels will also be high. So when galactose levels are high in the circulation, what will happen? It can go to the lens. It can just enter into the lens just like that. It gets converted to an alcohol form, which is called dulcitol. This is osmotically active substance. So it draws water inside the cell. So that will lead on to lens fiber swelling. That leads on to cataract. So there is a manifestation of cataract. So if there is deficiency of galactokinase, there is increase in galactose, which will lead to symptoms of cataract. Why this classical galactosemia is more severe? So that you should understand, the galactose gets trapped in the form of galactose 1-phosphate. So all of my phosphate is going to get utilized in this process, right? So it's not, I'm not going to release this phosphate at all because it is just going to get accumulated in the inside the cell. So this phosphate is not released. So this will lead on to decrease in inorganic phosphates. Yes, this will lead on to decrease in inorganic phosphate. Now, what is the main use of this inorganic phosphate? I want this phosphate to activate the enzyme called as glycogen phosphorylase, right? This glycogen phosphorylase is an enzyme of glycogen breakdown. Okay, glycogen breakdown. So if my phosphate levels are less, glycogen phosphorylase activation will be less. So in that case, glycogen breakdown will be less. So if glycogen breakdown is less, what happens? My fasting there will be the manifestation of fasting hypoglycemia, is it not? So this is what is the reason for hypoglycemia in the patients of classical galactosemia, right? So also, because I don't have all the phosphates levels are less, I don't have adequate ATP, so I have jaundice in these patients, right? Also, accumulation of all this will lead to hepatomegaly. So this is how severe galactosemia is severe in case of classical galactosemia. So we have brain damage, we have cataract, jaundice, enlarged liver, because of which you have hepatomegaly, bilirubin levels are high, the cells are damaged, you have kidney damage. Yes, so when in the infant itself, as soon as the infant is given milk, they will start developing these symptoms. So newborn having cataract, please think of only galactosemia, right? And if it is going to be severe, which is involving hepatomegaly, jaundice, then it is going to be classical galactosemia, which is due to deficiency of galactose 1-phosphate uridyl transferase. So this is all about this question. Next, we'll move on to the next question, which tells proteoglycan present in the glomerular basement membrane is. So it's going to be very easy. So why is it easy? Because it is nothing but heparan sulfate. So in glomerular basement membrane, you have the heparan sulfate. Okay. So this is what it is. So let's just revise all of the glycosaminoglycans. So these hyaluronic acid, heparan sulfate, chondroitin sulfate, keratin sulfate, dermatan sulfate. These are nothing but the glycosaminoglycans. So these are nothing but long unbranched chains. They have repeating units of uronic acid and amino sugars. They can be acetylated or sulfated. Now, what is heparan sulfate? Heparan sulfate, again, uronic acid, the thing is glucuronic acid, yes, or iduronic acid can be there. And you have amino sugars as glucosamine or galactosamine, sulfated or acetylated. Okay. Now, one exception is the keratin sulfate. Here, the keratin sulfate instead of uronic acid doesn't have uronic acid. Instead, it has galactose sugar. Okay, so this is what is one exception, keratin sulfate. Now, which has eduronic acid? Eduronic acid is present in heparin sulfate and dermatan sulfate. Eduronic acid is present in heparin sulfate and dermatan sulfate. So these things you have to remember. So functions, if you take hyaluronic acid, so hyaluronic acid you all will know it is found in the cartilage, in the vitreous humor of eye. It lubricates the joints, it provides the structural support, also helps in wound healing. Heparin sulfate, where is it present? It is present in the glomerular basement membranes. Okay, it is present in glomerular basement membrane. So it provides the negative charge for the glomerular basement membrane, which is why the proteins, when it reaches the glomerular basement membrane, they are repelled. Yes, so that's why you don't have proteins normally getting excreted in the urine. That is because of the presence of heparin sulfate in the basement membrane. Next, heparin, you know, it's an anticoagulant. It's present in the mast cells. Next, chondroitin sulfate, it provides tensile strength and elasticity in the cartilage and connective tissue. So it will be present in cartilage, tendon, bone, ligaments, right? Next, keratin sulfate, it's present in cornea. So it is responsible for transparency of the cornea. Dermatan sulfate is universal in distribution. So mainly, so they say skin, blood vessels, heart valves. So they're universal in distribution actually. So these are the important points that you need to remember on all these glycosaminoglycans. So now that you know the answer, glomerular basement membrane, which is more prominent, it's heparin sulfate. Now coming to the last question. Blood stored in citrate phosphate dextrose is better for hypoxic patients than the acid citrate dextrose. So in the stored blood, they would have added these preservatives like citrate phosphate dextrose or acid citrate dextrose, both of which are being used. But they say citrate phosphate dextrose is better. Why? The answer should be the fall in 2,3-BPG is less in case of in case of when you use citrate phosphate dextrose in the stored blood. But why do you need this 2,3-BPG? Yes, why do you need this 2,3-BPG? Because what is the function of 2,3-BPG, all of you? 2,3-BPG is 2,3-bisphosphoglycerate. It's a product of this Rappaport lubricant shunt. And this happens only in the RBCs. So in the RBCs only the Rappaport lubricant shunt is happening. Now here in this shunt, 2,3-BPG is a product. Now what this does is that it binds with the hemoglobin and it squeezes the hemoglobin to let out the oxygen. Okay, to let out the oxygen. So which means that if there is more of 2,3-BPG, then you have the oxygen affinity is going to be less. Okay, oxygen affinity is going to be less because the hemoglobin will take up a taut structure. So oxygen affinity will be less. So increase in 2,3-BPG levels are necessary for releasing the oxygen to the tissues. Okay, so in the tissues, the concentration of 2,3-BPG should be more for you to release the oxygen to the tissues from the hemoglobin. So the oxygen affinity should be less and also oxygen release should be more. So for which you will need increased 2,3-BPG. And where do you need this? You need this at the tissue level. All right. So in the stored blood. So first of all, what is the citrate phosphate dextrose? Okay, citrate phosphate dextrose, it means that it maintains better RBC viability because of its buffering capacity. Why? Because it has phosphate here. Yes, it has phosphate here. So due to the presence of phosphate, it has better buffering capacity. Also, it has because it has phosphate, there is adequate supply of ATP, and because of which also 2,3-bisphosphoglycerate, for which also you will need phosphate, right? So the 2,3-BPG levels do not get reduced so fast. Yes, so you will have adequate 2,3-BPG here. So only when you transfuse this stored blood to a hypoxic patient. So in a hypoxic patient, basically the patient would have hypoxic patient, the patient needs more oxygen to be delivered to the tissues. So you want to transfuse blood in such a way that the blood has the capacity to deliver the oxygen to the tissues. So for which I want to maintain adequate concentrations of 2,3 BPG in my stored blood so that as soon as I transfuse it to the patient, there will be adequate 2,3 BPG so that the patient can utilize it, right? So to release the oxygen to the tissues. So whatever blood that I have transfused has the higher capability of releasing oxygen to the tissues. So rather, if you don't have 2,3 BPG in the stored blood, this is a hypoxic patient who's already sick, right? So I can't assume that the patient would have adequate 2,3 BPG. All right, adequate RBC function, adequate 2,3 BPG levels. So that is why I am more concerned to deliver good amount of 2,3 BPG levels in the stored blood, transfusing that blood to the hypoxic patient. So for which I can use the preservative, which is the citrate phosphate dextrose. All right. So 2,3 BPG preservation happens is adequate here. So because this is critical for oxygen release from the hemoglobin. So this citrate phosphate dextrose preserves this 2,3 BPG level better than the acid citrate dextrose levels. So higher amount of this will improve the oxygen delivery to the tissue. So thereby it is helping the hypoxic patients. All right. Also for it stabilizes the pH during storage. So this is what it is. So this is all about this question. So that's why the fall in 2,3 BPG is less in case of blood stored in citrate phosphate dextrose. So now that you can understand the significance of this citrate phosphate dextrose, significance of 2,3 BPG levels in the stored blood when you transfuse it to a hypoxic patient who is already sick. Yes, so this is all about this. Yes, hope you enjoyed the session. So we'll meet you soon I'll meet you soon with another test and discussion video. So don't forget to attempt the quiz, the link of which is in the description box. Also, I have included the link of the app, so just download the app. The contents for NEETPG is going to be free. So you can just download the app here, right? Thank you all.